بسم الله الرحمن الرحيم. First of all, I would like to thank Professor Dr. Taher and Dr. The group of the Gastro Club. I'm honored to attend every year. Dr. Yusri asked me to talk about refractory Gerd in 10 minutes. I'll try to. Yes. As guidelines, all of us know, if a patient with a typical symptoms of Gerd, it is, and without alarming symptoms like dysphagia, bleeding, loss of weight, these patients, a trial of treatment with BPI for at least 2 to 4 weeks. It is the guideline said that, not to start with endoscopy or anything, a trial of treatment. If the patient responds to the treatment, we will continue for 8 weeks, and the patient later on may need maintenance dose treatment according to symptom recurrence. What we can face? We can face what we call patients refractory to PPIs. What is the definition of refractory Gerd? Refractory symptoms like heartburn or regurgitation, not responding to a double dose of PPI during a treatment period of at least 12 weeks therapy. This definition is controversial because it is subjective according to the patient's symptoms. They found that 10 to 40% of patients continue to have reflux symptoms or endoscopic evidence of esophagitis, what we call resistant or partial responders. تقريبا 10 ل 40% من العيانين. They found that 60% of these patients are NERD, non-erosive reflux disease. Also functional heartburn, where we do endoscopy and we find normal endoscopy and pH metry, has the lowest response to BPIs. 30% of cases of Gerd has dyspeptic symptoms. So we have a lot of causes. What are the underlying mechanisms of PPI failure? Timing adherence, this is number one. They found that about 50% of the patients, they don't take the PPI at the proper time. They said that we must take the PPI 30 minutes before breakfast. And we must stress this point to our patients. They found only 46% of these patients take it right. The second cause is the compliance of the patient. If the patient has, for example, constant health care coverage is not enough, the patient education, if the patient is taking a lot of drugs, he may omit a dose. Also, sometimes the patient feels well and he is off therapy for 2 to 3 days and then we start the treatment. The functional heartburn and reflux hypersensitivity, this represents 60% of these patients has functional heartburn. This is the most common cause. We must exclude major esophageal motor disorders like achalasia, reflux hypersensitivity, which is triggered by reflux events despite of normal acid exposure. So these patients will need what we call impedance pH monitoring. Also, non-acid reflux is one of the causes. This needs esophageal multi-channel intraluminal impedance testing as long as there is a residual pH testing under PPI. Bile acid reflux, 10 to 15% of non-acid reflux patients. And the effective treatment in these cases is baclofen 20 mg TDS. Also, nocturnal acid breakthrough is one of the causes because 70% of cases respond to BPI twice, where you can keep the pH below 4 for at least 1 hour at night. Difference in metabolism, we know that cytochrome P2C enzyme is responsible for metabolism of these PPIs, and we have some patients what we call rapid metabolizers. They will not respond to PPI. Reduced bioavailability, it is not with repeated dose administration. We don't see that. Drug resistance is very rare, mutation in proton pump gene, which is very, very rare. or delayed healing. They calculated that every week the rate of healing of esophagitis is 11.5% per week. So in 8 weeks, it is supposed to have all the patients cured, but there is delay in Los Angeles grade C or D category. H. pylori status, they said if H. pylori is positive for these patients, their response to PPI is high, but if you eradicate the H. pylori, it has no role. Psychological comorbidity is a very important factor. There is a poor correlation between the Gerd events and the symptom of the patient, what we call symptom index. And this patient has higher anxiety and hysteria. What is the differential diagnosis of a patient with refractory Gerd? Achalasia on the top, stricture, esophonic esophagitis, delayed gastric emptying, what we call gastroparesis. Non-steroidal anti-inflammatory drugs can experience pyrosis, rumination syndrome, pill esophagitis, and we have seen that when the patient swallows a pill with a little water, it sticks to the wall of the esophagus and can cause severe retrosternal pain and hyperacidity, candida infection, and radiation. What is the diagnostic tool in these patients? Number one, symptom evaluation. You must ask the patient about the timing of the taking of his PPI, and if he has heartburn and regurgitation, to exclude gastroparesis, dyspepsia, or associated irritable bowel syndrome, or psychological disorders. So evaluation of the patient by history is very, very important. The second step will proceed to endoscopy and biopsy. By this, we can discover cases like esophonic esophagitis, scleroderma, or achalasia. The last thing to do is esophageal manometry. Number one, to rule out achalasia or other motility disorders, and we can use it while the patient is off or on therapy better in these two situations. We have also ambulatory wireless pH metry, where a capsule is fixed at the lower esophagus, and we check the pH for 4 days. You will try to have 2 days on therapy and 2 days of therapy and compare both. And we have the multi-channel intraurinary impedance tests. This is the 24-hour impedance pH study. We have the catheter. We have here a pore for about 5 centimeters above the lower esophageal sphincter to measure the esophageal pH. The others will record what is the type of refluxate, if it is fluid, if it is air, if it is bile, and to see the motility during swallowing. This is very important, and it differentiates different types of causes of refractory Gerd. It detects acid or weak acid or non-acid reflux episodes. This is number one. It is superior to pH metry alone because it can detect also motility disorders. It evaluates the temporal relation between symptoms and Gerd, what we call symptom index. If the patient, when he feels the heartburn, he will press on a button. If it is coincide with the event of pH lowering, it is definite a reflux. It can measure the symptom index, especially when combined with M2. So what is the treatment? Optimizing therapy to check the compliance of the patient, timing, and the dose is very important. And all of us does not put strict on lifestyle modification, which I think is very, very important. If he's a smoker, stop smoking to lose weight, not to wear a tight thing on his abdomen, belt. Also, the drugs is very important to revive the drugs where the patient is taking the drugs, like calcium channel blockers can increase the weakness of the lower esophageal sphincter. Residual acid reflux, we adjust the dose of PPI dose or switch to doubling of the dose. Bedtime H2 receptor antagonists in cases of nocturnal acid breakthrough, but the problem of tolerance is there. Or treatment of delayed gastric emptying. We treat these patients like patients with gastroparesis. Treatment of esophageal hypersensitivity. This is very important. Usually in patients with refractory Gerd who have an unremarkable esophageal impedance pH study, and in patients with non-acid reflux, they suggest a trial of visceral analgesics, pain modulators, like tricyclic antidepressant, selective serotonin uptake inhibitor, serotonin norepinephrine reuptake inhibitors. The last modality is surgical treatment. Anti-reflux surgery should be considered in patients who require high dose of proton pump inhibitors to control symptoms. And if I have especially young patients and he has a long life, high dose PPI, it is better to do surgery for these patients. Surgery is not recommended in patients who demonstrate a complete lack of response to PPI therapy. If he is not responding to PPI, surgery here is not indicated. If we had no solution, this is the only solution we have, and nothing to help. Thank you.
Thank you, Professor Taher, for this precise presentation about the